Good morning, everyone. I'm going to speak on Avastin as in combination therapy. Over the last decade, Avastin has changed, made a paradigm shift in the management of most medical retinal diseases. However, there are some limitations to that. We'll discuss some of them. So, combinations with Avastin, various options include thermal laser, photodynamic therapy, corticosteroids by various forms, and sometimes in surgical cases as well. The rationale of combination is always to improve efficacy, minimize the side effects and complications. There are times when we use combination therapy as we're not sure which drug would act, and combine the two to avoid mistreatment or miss it. At times we also use combination therapy to support a gold standard therapy. For example, a laser case which would take time to have an effect, and to tide over that time and stabilize the disease early, give early recovery, we may use a combination. This ultimately is done to improve anatomical and functional outcome. So the most common use of Avastin has been in neovascular AMD, and we are aware that the neovascular AMD characterized by CNVM formation has a vascular component and a non-vascular component, which includes more mature vessels which are lined by myocytes and fibrocytes. So this is a schematic of a vessel which is maturing, a CNVM vessel. As this smooth muscle gets laid down around the vessel wall, these vessels become VEGF independent and so unresponsive to anti-VEGF as well. So photodynamic therapy has been used for neovascular AMD before anti-VEGF came into the picture. There are some certain limitations and complications associated with photodynamic therapy. It induces choroidal ischemia and consequent upregulation of VEGF. There are certain limitations of anti-VEGF as well that we have learned over the years. However, when combined, this may result into a better outcome. There are certain subset of patients, around 5% of them, which would progress in spite of a anti-VEGF therapy provided by a standardized way. And you may be left with an option of combination therapy where you can combine anti-VEGF with photodynamic therapy with or without steroids. With steroids, the treatment is called as triple therapy, and where steroids, anti-VEGF and photodynamic therapy would be acting on different pathways of the pathogenesis involved in the pathology. So PROTECT study laid down the foundation that photodynamic therapy in anti-VEGF gives good results, and subsequently FOCUS and SUMMIT trial gave some indication that it is safe and efficacious. However, there was no clear-cut distinction or benefit shown by combination therapy. The RADICAL study, which combined photodynamic therapy with anti-VEGF and dexamethasone as a steroid, showed that there is a tendency to reduce the number of injections and thus the treatment burden. Many trials and studies have been published over the years. The last, which is RADICAL study, shows the longest, the 24-month data, and shows a significantly reduced number of retreatments and treatment visits. Many other studies are going on, and there are many other drugs which would be then used in combination with anti-VEGF to provide a final answer. However, we have to wait till the results are out. So combination therapy in neovascular AMD, anti-VEGF with PDT, with or without steroids, is safe and efficacious when compared to monotherapy. It may reduce treatment burden at an extra initial cost. The best results of combination are shown in treatment-naive patients. However, the scanty literature precludes this as a first-line management, and first-line management still remains as monotherapy. So coming to PCV, where combination has been more studied, the lower VEGF levels in PCV as compared to AMD holds it as a distinct entity in most of the researchers. There are limitations of anti-VEGF therapy as it does not affect the polypoidal lesions and the branching vascular network. And when compared to PDT monotherapy, there may be a rapid resolution of the edema, the fewer hemorrhagic events, and reduced number of retreatments. So in combination with photodynamic therapy, combination appears superior to PDT monotherapy in terms of visual outcome and complications. However, there was no significant difference in the reduction of the retinal thickness, polyp or PED regression, and PCV recurrence. But the recent meta-analysis published in PLOS One suggests that long-term randomized controlled trials are the need of the hour. So in combination therapy in PCV, it's preferred, especially when there is a indistinct margin between the PCV and the neovascular AMD when ICG is inconclusive. It is an optimal treatment when PCV and choroidal neovascularization coexist. It provides superior results in treatment-naive patients as compared to patients who are recurrent and failed PDT. The fluence, the light dose, and the dose of anti-VEGF is yet to be standardized. There are people who have used half fluence, quarter fluence, yet not standardized, and the least and the most safe dose has to be customized according to the patient and the eye. When combined, it's best to perform them within 2 or 3 days of each other. Coming to diffuse macular edema, the combination therapy has become the mainstay now to limit the number of treatments and reduce the treatment burden. The ETDRS showed as well, the DRCR net as well, that there are patients who, following macular photocoagulation, would continue to lose vision. So anti-VEGF therapy has been the standard treatment now. However, it has limitations that it is not uniformly effective in all patients. Treatment burden by repeated injections and repeated recurrent visits to the clinic, and there are concerns about its ocular and systemic events in these seriously ill patients. So various studies like RESTORE, READ2 and DRCR net, they show that anti-VEGF is effective as laser photocoagulation in certain patients. However, the number of treatments can be reduced when they are combined with laser. So we can combine anti-VEGF with laser and with steroids, as well as they have different pathways of action. Ultimately, what we want to do is reduce the spongy edema, which will facilitate the laser and decrease the need of the laser energy. It may reveal unrecognized fractional component, as in this picture, which was very spongy initially, and now you can see there is a taut membrane over the retina. And more prolonged reduction in macular thickness is achieved when the treatment is combined with laser. However, there are some recalcitrant cases which may need to be treated with intravitreal corticosteroids or vitrectomy, and there is no additional effect, as is shown by many studies now, that when anti-VEGF is combined with steroids and monotherapy alone would have a different efficacy. The recent PLOS One meta-analysis suggested the probability of each treatment being the most efficacious. Ranibizumab monotherapy still holds the fort, and however, you can see that only laser treatment will not be much efficacious. It is very unlikely that it's most efficacious treatment, but when combined, they may do some good. So in PDR cases with diabetic macular edema, we know that when we institute a panretinal photocoagulation, there may be initial worsening of diabetic macular edema, and there may be some loss, transient loss though, of vision. When combined with anti-VEGF, you can reduce the morbidity or the effect of this transient worsening of macular edema. There are some pitfalls in use, as has been previously described. The longer the period between the Avastin and vitrectomy, the higher the risk of complications. In patients with uncontrolled diabetes, there will be transient worsening. PDR, which is resistant to PRP, it may not respond as well to anti-VEGF. And there are some reports of higher incidence of subretinal hemorrhage because of micro breaks formation when Avastin is used in PDR. So in which cases would you probably inject Avastin preoperative? And the first example, you can see premacular fibrosis and extensive fibrovascular proliferation on the retinal surface. And on ultrasound, you can see vitreous schisis and broad base attachments. So this is probably an indication for a pre-op Avastin. The second example, which shows a vitreous hemorrhage with insignificant fibrovascular proliferation and just point attachments, is probably a case we can proceed straight away with vitrectomy. So this is a case where we treated extensive fibrovascular proliferation with Avastin, and the 3 and 8 months follow-up shows satisfactory post-op outcome. So combination therapy in PDR allows for rapid clearing of vitreous hemorrhage and sometimes enabling PRP. It regresses the florid new vessels and reduces the intraoperative bleeding. Fibrovascular contraction may facilitate membrane peeling, and there is a reduced incidence of intraoperative and postoperative intraocular hemorrhage. There is a drci.net protocol which is pursuing this matter as an ongoing trial. In retinal vein occlusion, SCORE and Bravo and Cruz at 1 year have shown there are some patients who continue to lose vision with monotherapy alone. When combined in combination, there are only scanty literature, not proper randomized controlled trial. Ultimately, we want to have a more finite treatment, more definite treatment. So all these treatments, anti-VEGF, steroids and laser, when combined together may give a better outcome. In retinopathy of prematurity, there are certain clear-cut indications like an aggressive posterior ROP, where there is a poorly dilating pupil or a very sick baby which we cannot take for laser, and sometimes to reduce the area to be photocoagulated. So as a salvage therapy, anti-VEGF treatment has not been recommended by most experts. In ROP patients who are likely to go for surgery, preoperative Avastin would reduce the vascularity and the intraoperative and postoperative complications. So this is a case where the pupil was not dilating, and post Avastin, when the pupil became better, it was amenable to treatment with laser, and you can see the extensive laser which has been done and the disease stabilized. This is another patient which underwent Avastin injection, and you can see the avascular zone almost reaching zone 1, and the vascularization of the retinal vessels crossing over that area just with Avastin alone. So this may reduce the extent to which the laser may be required. This is the pictures from the BEAT ROP study published in NEGM, which shows clearly that the laser area is much closer to the fovea, and Avastin itself may help vascularize some amount of retina and preserve the visual field when the child grows up. This is another case where Avastin was given and had a satisfactory outcome with just Avastin alone. Certain indications like Coats disease and vasoproliferative tumors, laser photocoagulation has been the gold standard. However, with laser photocoagulation, there is a transient worsening of the exudation process, and this anti-VEGF therapy, when combined, can tide over this time. A possible synergy may exist with steroids. The steroids in young patients have more complications, so you can reduce the dose of steroids when combined with anti-VEGF. This is a case which did well with anti-VEGF and subsequently was lasered. In neovascular glaucoma, there is an initial IOP reduction. Regression of new vessels on the iris and anterior chamber will facilitate a good trabeculectomy or a glaucoma filtering surgery. There are other indications when combined with intravitreal steroids. It has been a way of management for post-inflammatory CNVMs. It can be combined with gas or vitrectomy in patients with CNVM and vitreomacular traction, with gas and TPA, for example, in cases with submacular hemorrhage, with anti-PDGF agents, which is the next drug coming up in neovascular AMD, and with systemic anti-cancer treatment in choroidal metastasis. So to summarize, combination therapy may help in improving the safety, efficacy, and reduce the treatment burden, thus improving compliance. It's a viable alternative to monotherapy resistant cases. However, options need to be validated by large randomized controlled trials. Thank you so much.